Okay, everyone, the Heart and Vascular Assessment is their last recorded lecture for the Health Assessment course. We're just going to quickly do some review on your vascular flow. You need to have a good understanding of it to be able to assess it. Just remember your blood is returning from your body unoxygenated through the superior inferior vena cavas into the right atrium. And from your heart, from your cardiac sinus to the right atrium. Right atrium pumps through the tricuspid valve into the right ventricle down here. The right ventricle pumps in through the pulmonic valve into the pulmonary artery, brings that unoxygenated blood to the lungs. It gets full of oxygen, comes back into the left atrium, through the mitral valve, into the left ventricle, and then the left ventricle pumps the blood through the aortic valve into the aorta of the body, bringing the oxygenated blood out to the body. Your next slide, should change slides here. It's a very busy picture, but again, it's looking at your flow, including your whole body with your hepatic vein, because as you get in med-surg and talk about portal pressures and hepatic vein and ascites, your renal veins, your iliacs, you need to have an understanding of these for assessment, management, treatment, what's going on in the body, and our carotid arteries, subclavian, all these things for your blood flow as we talk about flowing out to the body, the periphery, your pulses, and all of that. This I found an actual cute little musical quiz on the circulatory system. It's fun, it's easy. I strongly suggest you watch that little video. You can access it through your PowerPoint that I have uploaded. You can press on that link. So with your assessment, first you're starting up high, looking at your jugular vein. Should not be distended. This is obviously grossly distended here. You want to, when you assess it, put the patient at a 45-degree angle. And this shows the point of the angle of Louis. I always say looking at your clavicle, and I always did like finger breaths up. Think of 1 centimeter is about the width of a pencil. Most people's fingers are about the width of 2 pencils. So 2 or 3 centimeters up, or 2 or 3 finger breaths is where you anticipate, and greater than that is a distension. You should have no distension. If you notice here, your carotid artery, which is the red because it's oxygenated, versus your blue or unoxygenated blood, that you will visualize a pulsation in the carotid arteries, but you should not see distension in the jugular vein, and we will be practicing this in the lab with that assessment. Another that a lot of students will get confused is the base and the apex of the heart, because you want to, the brain wants the base to be at the bottom. So remember, this is the base of the heart is up here, which encompasses mostly the left atrium. And your apex of the heart down here is your left ventricle. And the heart sits in the body kind of at a tilt and angle, so your left atrium is more toward the surface area. Okay, so you've checked the jugular distension, looking for distension. Then you're going to inspect the precordium. Your precordium is that thoracic area in the front here, the area that's covering over the heart. Understand precordium versus pericardium. Pericardium is that fluid sac that encloses the heart and the proximal portions, the great vessels like this superior vena cava. The vena cava is coming in. That's your pericardial sac. Your precordium is that part of your thoracic cage that is covering your heart area. So you're going to inspect it. Again, you're looking at the skin, looking for scars, especially if they've had open heart surgery or they have an implant with a pacemaker, the AICD, automatic internal defibrillator. You're looking for any visible pulsations, deformities, and here's two types of chests where it is concave or going in is called your pectoral evacuatum or funnel chest. And then you have your pectoral here coming out, your pectoral carinatum or a pigeon chest. They sometimes will do surgeries if it's sometimes rare for cosmetic purposes or if it's impeding something. And think when you're doing your assessment, this may impact where you're listening for certain things. So you see the pictures here where you are looking from different views of the chest. Okay, your next, after you inspect, you will palpate. We will practice this in the lab. You see the fingers, which you're gently going with the fingers, feeling at the apex, which is that left ventricle. During systole, you may feel a thrill or like a up against your fingers, but you should feel it's called a PMI or point of maximum impact, where that left ventricle, you can feel it beating up against your fingers. You can feel it a little further right in here. The mid-clavicular, fifth to sixth intercostal space around the mitral valve and off to the side. If you can't feel it, sometimes you have to have the patient roll onto the left side and put your fingers there to bring the left ventricle up toward the wall so you can feel it better. Different type of things can change the position of that. Cardiomegaly, if you think of the wording, cardio meaning heart, megaly large. If you have a large heart, your point of maximum impact, PMI, may be deviated over to the side because that ventricle is enlarged. Also, when you're doing this assessment, you have them flat and you can put them up at a 45-degree angle to get a better assessment. Other things, if you have this shift of your thing, it could be because your lungs, multiple things can cause a shift. A collapsed lung will affect that. But we're just doing assessment here. Auscultation. I skipped percussion. You would inspect, palpate, percuss, auscultate. I am not going to have you percuss a chest as an RN. I cannot think of any instance where you will be doing percussion for a cardiac assessment, so we are going to skip that. So when you're auscultating, this is where you're listening to your heart sounds, which are telling you multiple things. You're going to listen in 5 places: the aortic, pulmonic, Erb's point, tricuspid, and the mitral area. The tricuspid and mitral valves down here are the ones opening from the right, the atriums to the ventricles, tricuspid in the right and mitral in the left. The tricuspid has 3 little valves in it, leaflets, I guess you can call it. They have a little mnemonic here that you can use. All people enjoy Time magazine. When I learned the heart sounds, we actually weren't doing the Erb's point, so I learned a poor tired mouse to get an idea where these were. It's just APETM. So we talked about these previously, but now we are actually going to practice it. So on this picture, you see your first listening point is your second intercostal space on the right sternal border next to the sternum. It's between your second and third rib. It's your second intercostal space on the right. Next, you're just going to slide straight across to your pulmonic area, which is your second intercostal space between the second and third rib on the left sternal border. Slide down one to your third intercostal space, which is between your third and fourth rib on the left sternal, just to the left of the sternal border. Your tricuspid is the next one down, which is your fourth, by your fourth rib, and it's actually just the left aspect of the sternum instead of in the intercostal space. It's right there on that sternum. And then your mitral area, mitral valve, you will hear best around the fifth, sometimes the sixth intercostal space in the mid-clavicular line. Here's your clavicle, and slide down. And it's usually the same place where you're going to feel your PMI, your point of maximum impact. As you can see here, it shows your mitral valve, your left ventricle, where your pulsation is, because that's the valve that's opening between the left atrium and the left ventricle. You should hear clear, crisp sounds as they open and close, and we're going to go into different murmurs and things that change what sound you're hearing. When you are listening, you are first going to listen with your diaphragm, the large flat part of your stethoscope, and hear the sounds. After you hear them, you will flip over to your bell or do a lighter pressure if you don't have a bell, listening for extra sounds, different kind of sounds, and we're going to go into those here. So when you listen to the heart, lub-dub is what you'll hear people say. I recommend when you're listening, close your eyes, get the sound in your head, and just find your place. Find what it sounds like to you when you're listening, and just listen for a while in that first aortic area. Just sit there and close your eyes and listen to bum 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 to the closure. It's the closure of first your S1, that's what they're called, your S1 and your S2. Your S1 is when your mitral and tricuspid valves are closing so that your atrium can fill up, and your S2, second sound, is when the atrial and pulmonic valves up higher are closing. Here on your S1, when you have your mitral and tricuspid valves are closing, those are called your AV valves, atrial ventricular valves. Again, mitral, tricuspid, because it's the valves that are between your atrium and your ventricle. Over here, your mitral, this is your tricuspid, this is your mitral on the left, atrial ventricular valve, or AV valves. Those valves open during diastole, so the two ventricles can fill with blood. And then you have your S2, when the AV valves, these same valves, close, so that during systole, so the blood can be pumped out to the body and there isn't a regurgitation or blood coming back in as the blood is being pumped into the left atrium and the aorta out to the body. You can hear split sounds. It's due to usually just because they don't always close at the same exact time. And sometimes that's a pathology, meaning something bad. Sometimes it's not. And this is not the course we're going to get into it. Oh, I don't have this highlighted. There is actually a link here that you should be able to see better on your PowerPoint that I have loaded up for you to be able to follow and listen to this audio. Oops, next slide. talk briefly on cardiac murmurs. This is strictly for assessment purposes because you will get this more in your med-surg as you're studying the cardiac system and complications. Just want you to have an understanding of the blood flow and the functions and what murmurs are. Heart sounds video that I have a link again. You'll have it in your PowerPoint where you can access that link to listen to this heart sounds video that talks about the valves. And a murmur is a gentle blowing or swishing sound that's heard on the chest wall. It has to do with the blood flow. The velocity is your blood flow. Viscosity of the blood decreases in anemia, and because that causes the pump to heart to pump more blood, trying to bring more oxygen through, so you have a more turbulent flow. If there's a defect in the valve, a narrowed valve, incompetent valve, you can have a stenosis, where the valve itself is stiff, non-compliant, and you can have a regurgitation, where the valve is just not competent. It doesn't close all the way, and will cause this swishy murmur sound. More sounds are your extra sounds, or your S3 and S4. Again, on your PowerPoint, you will have these links that you can access. They're very short little videos where you can listen and get more explanation in the S3 and the S4. Just think of it as S1, S2, S3. S1 is your S3 follows your S2. Your S4 comes before your S1. So your S3 is Kentucky, 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 Kentucky. It sounds exactly like Kentucky to me when I hear it, and I think of a horse galloping, Kentucky, 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 and you have that high, and then coming back down, that's exactly what it sounds like. Your S4, which comes right here before your S1 sound, to me sounds like Tennessee, Tennessee, Tennessee. It's like you have two sounds and then one. Tennessee, Tennessee, Tennessee. When first time you get to hear it, say those words in your head and see if you can locate it and see what's happening. The S3 can be normal or benign in young children, young adults, and pregnant women due to blood flow. Otherwise, it can be a sign of heart failure. So when you listen to heart sounds, you're listening to the intensity, which is the loudness or softness of it, listening to its pitch, being high with the diaphragm. So your S3 is called your ventricular gallop. Think of it being due to the ventricle. Your S4 is called the atrial gallop. Now your S4 is when that active filling, let's see. So both are occurring with the filling of with your ventricle. So the S3 is when the blood just starting to flow with the ventricle, but not an active pumping into it. And so you have this compliant ventricle, and you might hear, should not hear, but with more volume of blood flow, you might hear that S3 from the blood flowing in. Your S4 is when it's active, pumping of blood from the atrium to the ventricle, and that ventricular wall is like boggy or large from hypertrophy, being too expanded, a hypertensive person. So the left ventricle is not very good. It is non-compliant, and you'll hear this sound. Here's a little picture that might help you on your S1, S2. Put it in here to help you think of the opening and closing of the valves. And between this and you listening to that video, watching some of these links I put in, hopefully is going to give an understanding. You will get this in med-surg much deeper. And then again, in comprehensive med surg or critical care at the end when there's complications. For assessment, just understanding what you're listening to, why you're listening to it, when it's normal, when it's abnormal. Okay, we covered peripheral vascular very briefly in the beginning of this course. I've stuck it in again here as we finish up with the vascular system because of the heart pumping and circulating through the body. It's also going out to your extremities. So when you're doing your inspection, of course, you're looking at color. You're looking at symmetry to both sides, both arms, both hands, both legs, both feet. Does everything match? Do they have edema, swelling, extra fluid? Clubbing, this is where I put this picture here of clubbing, which is a bulbous, you could see that bulbous enlargement of the distal phalanges. You see it's not just the nail, but the fingers itself on the ends of your phalanges of the fingers and the toes. They're just enlarged and the nails are very pale and bubbled up. It's due to a chronic cyanotic heart disease or a lack of blood flow due to heart disease or a significant lung condition. So their body has gotten used to the cyanotic or lack of oxygen state. This is your upper extremities, even though the clubbing includes your feet. So inspecting the arms for color, symmetry, edema, clubbing. You're feeling temperature, that has to do with your blood flow. The texture of your skin, again, your flow. Capillary refill, it should be less than 3 seconds when you press down and release and watch the refill. And how strong are the pulses? So put a slide in here on palpating and grading your pulses. Always feel with the pad of your 2 fingers, your index and middle finger. You're checking for the rate, regularity. Is it fast? Is it slow? Is it irregular? Is it strong under your fingers? Anything you can. And here, bounding is 4. Here, socks or stockings, if you do in the feet, which we're going to do in a minute, you have to remove them to actually feel the pulses. 1 is diminished, 2 is normal, 3 is increased, 4 is pounding. So you need to be practicing this on each other, on more than one other student or other people to start getting the feel of the differences in the strength of those pulses. So continuing peripheral vascular, your low extremities, again, you have your color, inspecting your color, looking at hair distribution on your lower extremities as in med-surg as you learn more about problems, complications, lack of blood flow, arterial or venous, because it could be either. You will notice lack of hair due to arterial. So you're looking for hair distribution. You're looking for varicosities, which are those enlarged, engorged, twisted up veins. And I do have a picture of that in here for you. The size of the lower extremities, not just looking for swelling or edema. You're also looking for atrophy or wasting of that limb. And then again, symmetry, which I didn't put here. You're looking for any lesions or ulcers. Later in med-surg, you'll learn the difference of where the ulcers will be due to lack of arterial blood flow versus lack of venous return. Remember, your veins are carrying your blood away, the unoxygenated blood away. Your arteries are carrying your oxygenated blood to the extremities. So the oxygenated blood to the extremities. If you're not getting oxygenated blood, it's going to be cold and pale. If you have good arterial flow, but you don't have a venous return, little valves that they have to go through, return of blood, if they get faulty, they're not working real well, blood is pooling below those valves. As the blood pools, the skin gets red, ruddy, warm, and edema. Okay, so your temperature, Hohenstein, we will practice that. We'd always pushed on the bottom of the foot, and if they had pain, up the back, kind of deep, due to a deep vein thrombosis. They no longer consider that to be a valid test for a blood clot, but you still need to learn about the Hohenstein. Tenderness in any area, again, your capillary refill, grading your pulse. Also, you're going to grade edema, and I did include something for that. Here is a very good chart that I found. to help you in understanding what you're looking for, what you're accessing, like I mentioned here about arterial supply and your venous return. And we will practice that in lab. These are different things you're going to do when you're assessing for your swelling. And so be familiar with this, and we will practice it in lab. This is a really good picture, an explanation of pitting edema. Pitting is where you leave an indentation. Not all edema is pitting. There can be fluid, but you press and it doesn't stay. It doesn't indent at all. And this is really good explanation on the mild being slight indentation, 2 being indentation that goes away within 10 to 15 seconds, 3 plus indentation lasts less than a minute, but the legs look swollen. 4 plus indentation lasts 2 to 5 minutes and legs look very swollen. Even though we can't time it here, I would guess that that's a 4 plus. Here's some other pictures for you. This one here, your varicosities, all those big, twisted, tortuous veins that the valves aren't working, so the blood is pooling in them instead of being able to pump back up to the heart. Ulcerations can be different places, different degrees, depending on whether it's due to arterial or venous flow. But this was just to give you a picture of this erosion off the top surface for an ulcer to form. When you're doing your assessment, you have your subjective data. Comes to the cardiovascular system. Remember, not just cardiac, but the whole vascular system. Chest pain, shortness of breath, and dyspnea. Sometimes those are used interchangeably, sometimes not. Short of breath, it's feeling winded. To me, dyspnea is having difficulty, pnea, P-N-E-A, breathing. Orthopnea, that is not being able to lay flat. One of your questions are how many pillows do you have to sleep on? 1 pillow, no pillow, 2, 3, 4 pillows, have to sleep in a recliner because of orthopnea, because they get dyspnea or difficulty breathing when they try to lay flat. Cough, is it a wet cough, a cough when they're trying to lay down? Cough is not necessarily a respiratory issue. It can be a sign of a cardiac issue. Fatigue, and asking about their level of fatigue, what makes it better, what makes it worse, when does it come on? Because if you don't have blood flow, enough oxygen going out, you will be fatigued. So it also can be fatigue of their extremities, fatigue of their legs, because if there's poor arterial flow carrying oxygen to their legs, the legs can be fatigued. So be specific on that. Cyanosis or pallor, cyanosis being a bluish tint, pallor being pale. I should have put on here also a ruddy, which is the blood pooling from a venous problem, venous insufficiency. Lesions on the legs, which could be ulcers, healing or not healing, how long they've been there, where they're located. Edema, which may or may not be pitting. Looking for any skin changes, which would include hair loss or lack of hair in places that should have hair. Nocturia, that's getting up to pee during the night, nocturia. Tiring easily, which is different from fatigue. Fatigue is they're just like it's all taken out of them. Tiring easily, they walk a little and they just have to stop. And do they have any past cardiac history, family cardiac history, and asking about personal habits for their cardiac risk factors. So some things you want to ask about is a history of hypertension or high blood pressure, elevated cholesterol or triglycerides. You're thinking of blockages, plaque. Do they have a history of heart murmur, congenital heart disease? Were they born with a defect? Have they had surgery? Did they have any rheumatic fever any point in their life? Did they have unexplained joint pains as a child or youth? Of recurrent tonsillitis, or do they have anemia? The tonsillitis, you're thinking of a strep throat. Also there, anemia, because the anemias, if it's an iron deficiency, you're not carrying your oxygen on your cells out to the body. Have you ever had any heart disease? When was it? How was it treated? Are you on medication for it? Did you have heart surgery? When did they last have an EKG or ECG, electrocardiogram? Have they ever had a stress test or stress electrocardiogram, cholesterol levels checked, any kind of heart test at all? In family history, not just when I say family cardiac history, history of hypertension, risk factors, yourself or family, or obesity, diabetes, coronary artery disease, anybody that had sudden cardiac death at a young age. If there's a family history of heart disease, mother, father, and what age did it first occur? Terms, we covered many terms throughout this lecture. Some additional terms, I may have covered some of these, just in case I didn't. Angina pectoris is acute chest pain when there's not enough oxygen getting to that heart muscle. Doesn't necessarily mean heart death, heart muscle death, but it is when there's a lack of oxygen getting part of it, they get that pain, that chest pain. Bradycardia is when the heart rate in the adult is less than 50, compared to over here, tachycardia in the adult is when the heart rate is greater than 100. Cyanosis, I mentioned, a dusky blue or mottling of the skin. Dyspnea is that difficulty or labored breathing. Edema is the swelling of the legs or a dependent part, and you will document as dependent edema. So if their legs are edematous, they raise them up and the edema gets better. That's a dependent edema. Ischemia is a deficient arterial blood flow to any part of the body. Left ventricular hypertrophy, which I mentioned, you'll see it listed as LVH, when that left ventricle wall is very thick and so the heart is pumping against that pressure, that thick wall. Orthopnea, I mentioned, was difficulty breathing when laying flat, so you're asking how many pillows they're on. Palpitation is just an awareness of a rapid or regular heart rate. It will come and go. Pericardial friction rub is a high-pitched, scratchy sound heard with the heart sounds when the pericardium is inflamed. Remember, your precordium is that thoracic region in front of the heart. Your pericardium is that fluid-filled sac around the heart. So when that pericardium gets inflamed, you will hear the scratchy sound that goes not with your breathing, but with your heart sounds, because you can have a pleural rub, which is that scratchy, leathery, squeaky sound with the breathing when the lungs are expanding and that sac has inflammation, versus the pericardial friction rub, which is when the heart is pumping. So with the heart sounds, that inflamed pericardial sac around it, you'll hear that scratchy sound. Regurgitation, I mentioned, it was the incompetent valve. One type of murmur is due to the regurgitation because it's a backflow of the blood, and the stenosis is another type of murmur because of stiffness or calcification where that valve just doesn't quite open or close completely because it's stiff. It has very little movement. Syncope is a temporary loss of consciousness due to decreased cerebral blood flow to the brain. Is a fainting is syncope. Syncope is not dizziness. It is a loss of consciousness or fainting briefly. I mentioned tachycardia already. Thrill is what you're doing when you're palpating the chest. You're palpating that vibration on the chest wall. And there's a couple places you may feel a thrill, but you definitely should at the point of maximum impact, or PMI, in the mitral area around the fifth intercostal space, left mid-clavicular line. Thrombophlebitis is an inflammation of a vein associated with a thrombus or clot formation. Varicose veins we mentioned, which is that dilated, tortuous vein due to incompetent valves in the vein, and the ulcer I mentioned could be venous or arterial, and it's opening in the skin lesion with some depth as the picture showed you. And that is the end of this Recording, thank you.